Hello, I'm Dr. Tedesco D.O, Associate Program Director of Good Samaritan Regional Medical Center's Orthopedic Surgery Program, and I'm here today to talk about extremity metastases as part of our online lectures that will supplement the in-classroom case-based learning presentations. Once again, I do own stock in ROM Technologies, which is a small orthopedic rehabilitation company, but has nothing to do with this talk. So the first thing we'll talk about whenever we're discussing metastatic disease is the differential diagnosis of a bony lesion that's found in a patient greater than 40, because metastatic disease tends to be the most common. However, there are many other things that need to be ruled out. Metastatic cancer is most common, followed by multiple myeloma, lymphoma, a primary benign, or a primary malignant bone tumor. There are less than 2,400 primary malignant bone tumors diagnosed in the United States each year, and then metabolic bone disease can also manifest as a lytic bone lesion. Most metastatic diseases will metastasize to the lungs, followed by liver, followed by bone, followed by brain. When lymphoma is found in a bone, it's most commonly the non-Hodgkin large cell B cell variant. Gorham's vanishing bone disease is another non-tumorous process that involves severe osteolysis with and due to sudden and local angiomatosis, with or without extremity elephantiasis from lymphatic pressure by the angiomatosis, and there are less than 200 case reports of this in the literature. Klippel-Trenaunay-Weber syndrome and other syndromes of high blood flow resulting in a vascular steal phenomenon can also create lytic bone disease that can mimic a tumor. Epidemiology of metastatic disease is that 280,000 patients are diagnosed each year in the United States with metastatic bone disease. The most common bony metastases are breast, lung, kidney, thyroid, and prostate. The common mnemonic for this is BLT with a kosher pickle, with colon cancer a distant sixth. In terms of what it looks like when it's in the bone, lytic disease tends to be lung, renal cell, thyroid, colon cancer, and breast cancer. Blastic disease tends to be prostate cancer, breast, and colon. So you can see breast and colon both have a mixed lytic and blastic picture. The most common locations for bony metastases are axial followed by appendicular in a proximal to distal direction. You need to differentiate metastases from osteomyelitis, and that metastases typically do not involve the intervertebral disc, while osteomyelitis does. Acral metastases are metastases distal to the elbow or knee, and these are most commonly seen in lung cancer, followed by renal. However, they can occur in virtually any cancer, just with much more rarity. Prognosis and median survival in metastatic bone disease is generally very poor. This is taken from 2017 Danish registry data that showed that melanoma, once found to be metastatic to bone, the median survival is only 3 months. Prostate cancer, 7 months. Breast cancer, 12 months. Kidney cancer is highly variable depending on the degree of metastatic burden, but approximately 6 months for all comers. And lung cancer, only 2 months median survival. Here is 1, 3, and 5-year survival for common disease that metastasizes to bone, and the hallmark here is when you look at 5-year survival for stage 4 cancer with metastasis to bone, breast cancer at 13% is the highest. Many of these cancers are between 1 and 5% 5-year survival. So prognosis is generally grim, although there are a few outliers that are able to survive long term with widely metastatic disease. There are several requirements in order for a tumor to metastasize. Osteoblastic bone metastases are due to tumor-secreted endothelin-1, but otherwise the way the tumors get there is that tumor cell intravasation has to happen first. E-cadherin is a cell adhesion molecule on the tumor cells that modulates their release into the bloodstream. Once they're in the bloodstream, they need to avoid immune surveillance and travel around the body without getting picked up. The next thing is they need to localize their target tissue, whether that's lung, liver, bone, or brain. Then what they will do is that they will attach to the target organ endothelial layer via integrin cell adhesion molecule expressed on the tumor cells. They then need to extravasate into the target tissue. They then need to induce angiogenesis via the vascular endothelial growth factor pathway in order to gain their own blood supply to be able to continue to grow. They also have to have enough genomic instability that apoptosis will not occur. Once all of these are present and provided for, the tumor can easily metastasize and spread to multiple organs. So the typical presentation of bony metastatic disease is often progressive pain that becomes unrelenting and worse with weight bearing or at night. Pain that's worse with weight bearing is known as functional pain and is some of the most concerning findings for impending pathologic fracture and significant structural damage to the bone. They may have a mass effect as the tumor continues to grow outside the bone and may compress neurovascular structures or cause pain on adjacent structures. They may have a history of a primary cancer, but it can take 15 or more years to metastasize, so a remote history of primary cancer does not necessarily rule that out as a potential cause for the present metastatic disease burden. They may have also had a history of radiation therapy in that region, especially in breast cancer, where this could actually be a secondary radiation-induced tumor as opposed to a relapse of the original primary. Causes of the pain are multifactorial. You can have bone destruction and weakening leading to near fracture strain with low stresses. You can have tumor-mediated cytokine release that enhances the inflammatory response and increases pain. And you can have local mass effect on nerves or other structures that can cause significant pain. The typical workup for an unknown diagnosis when you see a lytic lesion in a patient greater than 40 was initially sort of established by Rugraf, Niesel, and Simon at the University of Chicago. What they found was that they could get the primary diagnosis in about 85% of patients without the need for a biopsy, and by adding biopsy to the lesion, an additional 8% could be found, which at the time, back in 1992 when this paper was written, left the diagnosis of about 92 to 93% where we could get the diagnosis. About 7% ended up carcinoma of unknown origin. As our pathology has improved, our immunohistochemical staining has improved, and our understanding of tumor genetics has improved, the diagnosis of carcinoma of unknown origin is becoming more and more rare, although this does still exist. What Rugraf, Niesel, and Simon found was that if you take a full H&P, including a history of when their last mammogram was, or PSA or prostate exam, as well as family history, if you obtain labs including a CBC, ESR, CRP, CMP, including LFTs, and then an SPEP and UPEP, follow that with advanced imaging, including a whole-body bone scan, a plain radiograph of the site in question, and a CT scan of the chest, abdomen, and pelvis. This is how we are able to get about 85% of the diagnoses. So the biopsy typically should be a CT-guided core needle biopsy or an open surgical biopsy with meticulous hemostasis. That would include bone wax or even PMMA as needed after you remove a segment of the tumor from the bone, depending on what you have structurally there to prevent tumor extravasation into the tissues and excessive hematoma formation. You want to biopsy the most accessible lesion found on staging if the diagnosis is not known or presumed. If they have known metastatic disease, but the lesion is not consistent with the known diagnosis, so you're now suspecting maybe a primary sarcoma or a second metastatic carcinoma, then a biopsy is still needed. You always want to biopsy the first metastasis or suspected metastasis that's found, even when they have a known history of cancer and the lesion is consistent with that known cancer. If they have a known primary cancer history, but only one lesion is found in the skeleton, you must biopsy that lesion. You still need to rule out a primary sarcoma. Immunohistochemical staining of the lesions to memorize to help you get which one is which in terms of the diagnosis of common carcinomas metastatic to bone are going to be an S100 for melanoma, CD20, 45, 3, or 30 for the B and T cell variants respectively. Thyroid and lung will both be TTF1 positive. Breast will be estrogen receptor or progesterone receptor positive. And prostate-specific acid phosphatase for prostate cancer. Full staging includes a plain X-ray of the site, a CT scan of the chest, abdomen, and pelvis with contrast, and a whole-body bone scan, as we just talked about. The whole-body bone scan only detects osteoblastic activity, so it's commonly false negative in purely lytic lesions, including multiple myeloma, eosinophilic granuloma, renal cell cancer, and thyroid cancer. So in those particular diseases, if that's what's suspected or known as a primary cancer, when you're staging them, you need a skeletal survey instead that gets plain x-rays of the entire skeleton where you can detect lytic bone disease in multiple bones. PET scan is now also becoming a good tool to use for lytic bone disease because of the PET avidity. However, the cost of this is difficult and getting it through insurance is difficult. The bone scan is positive up to 3 months before the lesions are apparent on the x-ray. That's why they can be helpful even when a skeletal survey is negative. You need 30 to 60% bone loss to be apparent before it becomes visible on the x-ray. Osteoclasts and not the tumor are typically responsible for osteolysis, and usually via the rank and rank ligand pathway. One of the things that's been tested in the past is breast cancer. Breast cancer stimulates the TGF-beta pathway, which stimulates release of parathormone-related peptide. This then stimulates osteoblasts to secrete rank ligand to activate the osteoclasts. This destroys bone and releases more TGF-beta in a vicious cycle. An FDG PET is not always indicated for staging, but is useful for monitoring treatment response. It's less sensitive and specific than a CT for pulmonary mets. So in addition to a whole body PET CT, when you are using this as a staging study, you also still have to order a dedicated CT scan of the chest. An MRI with contrast from the joint above to the joint below the lesion may be helpful to evaluate for skip lesions or soft tissue extension when concerned about either of these phenomena. Treatment really is reserved for once the definitive diagnosis is known. If you don't have the definitive diagnosis, you have to go back to that workup and possible biopsy. Chemotherapy or hormonal treatment are the mainstay for metastatic disease. They provide reliable palliation in up to 70% of patients and may improve survival rates by up to 6 months or more depending on the disease and depending on tumor markers that may be targetable. There's an increased risk of thromboembolic disease in these patients, especially when considering surgery for an impending or actual pathologic fracture, so you do need adequate prophylaxis. The problem is adequate prophylaxis has not been clearly defined. We have studied these patients using multiple different low or heavy duty blood thinners, and unfortunately what we find is the rates of thromboembolic disease remain the same. So there appears to be more involved with the tumor-related factors that increase coagulopathy that are not quite affected by a lot of the drugs that we have available. So essentially, close monitoring is what's needed for these patients. You can consider resection of the tumor if it is a solitary met, especially in renal cell, thyroid, or occasional breast cancer, especially because most metastases in those diseases are usually present on their first presentation as opposed to developing late. However, even if they develop late, this still can actually be curative in a small subset of patients with removal of the primary tumor. Not always, but in those particular diseases that we just mentioned, you can prolong survival with resection of certain metastases depending on the degree of metastatic burden. Resection is considered in radiation-resistant cases or in cases that already have been radiated and the tumor continued to progress, especially when the patient has severe morbidity secondary to the presence of the tumor. And then what you'll need to do is reconstruct that area, either an intercalary device if it's diaphyseal, an endoprosthesis if it is epiphyseal, or osteosynthesis as indicated depending on the exact location and the methods for resection, whether it's a full end block resection or just a curettage. Resection as endoprosthesis is indicated only when you have greater than 3 months of life expectancy left with a metaphyseal or epiphyseal lesion and impending or actual pathologic fracture. And that's because the recovery from a surgery of that magnitude with a reconstruction that significant needs at least 3 months for the patient to see the actual benefit of that treatment. Radiation is indicated for radiosensitive lesions and always as a post-op adjuvant for impending or actual fracture that's fixed, especially when there's not an end block resection that took place with wide resection and negative margins. Usually this is going to be 30 gray and 5 or 10 fractions, usually reserved for palliative or debulking and pain control if the patient is non-operative, such as their prognosis doesn't warrant surgical fixation. Pain control due to tumor debulking and decreasing pro-inflammatory cytokine release from tumor cell death does occur with the radiation. This does not actually improve mechanical stability, and thus stabilization may still be indicated if pain persists after radiation, because impending mechanical failure might be the culprit of pain production as opposed to presence of tumor itself. Sometimes you will see the bone rebuild itself, but sometimes the tumor just turns to scar tissue but blocks the bone's ability to reconnect itself. So that's why radiation alone may not necessarily create the desired outcome. So you have to look at that individual patient, their goals, the location of the tumor, whether or not in a weight-bearing or commonly used bone, the presence of destructive disease, whether or not it's a disease that's known to typically be radiation sensitive, and what the patient's survivability is. There's a higher risk of implant failure if there's no post-operative radiation therapy used, again because of local tumor progression, continued destructive changes in the bone. Now the implant takes all of the force and eventually the implant will break. Renal cell is the only common met notorious for being both radio and chemo resistant. So newer anti-angiogenic agents are what we use for this. The problem is those anti-angiogenic agents prevent healing post-operatively. So patients that are on those need to have their medication stopped often 6 weeks before surgery, and they need to stay off until the skin is completely healed, usually 2 to 3 weeks after surgery. So the other thing about discussion with these patients is also, can they tolerate a chemotherapy holiday that long, or is their disease likely to progress quickly? Bisphosphonates are commonly used to decrease pain, decrease the risk of fracture, and treat hypercalcemia that's associated with metastatic disease. Exjuva or denosumab is a newer agent out there that's anti-rank ligand on the osteoblast that decreases osteoclastic activation. This decreases pathologic fracture risk and tumor-related impending fractures a little bit better than bisphosphonates. Side effects, though, for both of these agents are obviously the atypical femur fracture shown there on the right, marked decrease in serum calcium, and so therefore this is contraindicated in renal failure, hypocalcemia, or hypoparathyroidism. These can also cause osteonecrosis of the jaw and bone pain. So, for impending pathologic fractures, CT is the test of choice to evaluate bony destruction. Union rates are only 35% after pathologic fracture, possibly owing to radiation, possibly owing to the survivability of the patient not being alive long enough to see union. So this is directly related to time of survival. There's a 74% union rate in those who survive greater than 6 months, but even at that, there's still a quarter of patients at 6 months that have not healed their pathologic fracture. Multiple myeloma does tend to heal the best with 67%, and lung mets the worst with 0%, again owing to survivability. Rigid internal fixation improves union rate by 23% versus immobilization alone. PMMA can help secure fixation and doesn't affect union rates. Total radiation dose less than 30 gray does not inhibit callus formation either. So that's why radiation still usually doesn't necessarily affect fracture healing. Pathologic fracture can spill tumor into the surrounding soft tissues, contaminating multiple compartments that may change definitive management from limb salvage to amputation and or worsen prognosis. So that's always something to be considered, especially if still going for cure with a resection. After pathologic fracture, the mean survival of patients is about 18.6 months. So when do we fix bone? Well, one of the older criteria we use is something called the Harrington criteria, where surgery was necessary if 2 or more of the following were present. So a lesion greater than 2.5 centimeters in the proximal femur, pathologic avulsion of the lesser trochanter, persistent stress-related pain following radiation, or greater than 50% cortical diameter destruction. Cortical diameter destruction is basically defined as the highest amount of destruction of any cortex compared to the normal cortex. It has nothing to do with the size of the lesion. There are current and ongoing studies using dynamic stress CT for determining at-risk lesions. However, there's questionable utility for this in terms of the technology required and that being applied even to small community centers, and then obviously the cost for this. And so really what's used most often to determine when to fix a pathologic fracture is the Morell's criteria. What he did was he looked at lesions that did fracture and tried to determine what were the big risk factors. And they created 4 different categories with a maximum score of 3 in each category, so a total possible score of 12 and a minimal possible score of 4. Those with scores less than 7 had a very low risk of fracture, and so you can consider radiation alone if they're painful, or observation with their continued chemotherapy or hormonal therapy as indicated. Score of 8 was associated with a 15% risk of fracture. So this becomes surgeon preference to fix or not, again, more depending on location and on the symptoms for the patient. And then those with a score greater than or equal to 9, the risk was 33% of fracture. And so the conclusion was that anyone with a score of 9 or greater should probably undergo prophylactic fixation. So here's a chart showing the Morell's criteria, where they looked at the site, the pain, the size, and the type to determine those 12 points. So upper extremity gets less points because it's not a weight-bearing extremity compared to the lower extremity, and the proximal femur is the highest risk of fracture, so that gets the most points. In terms of pain, mild pain just means it doesn't really bother them, or maybe only occasionally, but it does not debilitate them. Moderate pain is pain that causes them to take medication or bothers their activities of daily living. And then severe or functional pain is, as we talked about, incapacitating pain with any attempted motion or weight bearing. Size of the lesion matters in terms of the relationship to the cortical diameter of the bone. So less than 1/3 gets 1 point, greater than 2/3 gets 3 points. And then the type, blastic, tends to increase strength of bone, so it has a much lower risk of fracture. Therefore, blastic metastases only gets 1 point, and lytic metastases that are eating the bone away are more destructive, more likely to cause structural damage, and those get 3 points. So once you've decided to fix an impending fracture, or you have to fix an actual fracture, there are many principles of treatment that must be followed that are slightly different than typical trauma principles. First is you want to try and fix the entire bone if possible, especially if it's a high-risk lesion for polymetastatic disease. In other words, an intramedullary nail may be better than plate osteosynthesis, again, depending on the underlying disease. You must follow prophylactic fixation or fixation of a pathologic fracture with radiation therapy to halt local disease progression before it eats away the bone and, again, transfers too much stress to the implant that will then cause implant failure. You always want to biopsy the lesion, either by direct open biopsy or by reamings, unless it has been biopsied already and confirmed a MET. Even in polymetastatic disease, what I will do is I will use the reamings just to confirm that indeed it's exactly what we thought it was. You want to reinforce structural defects with polymethylmethacrylate, as you can see in this image on the right with the plate and the cement. What the cement does is it allows for immediate structural support. Something that we don't have time for in a lot of these patients is to see bone graft take. So bone grafting the tumor cavity is not helpful in these patients because many of their life expectancies is shorter than the bone graft to take, and in the meantime all of that stress is on the implant, which may hasten failure. So this is the way of reproducing both bone and implant structural support to get everything as strong as possible right away for the patient. The goal is to provide a stable load-sharing or load-bearing fixation construct so that the patient can be weight-bearing as tolerated with full active range of motion immediately post-operatively. What we know is if you fixed everyone's fracture like this, eventually this would fail in a young patient because they don't get eventual biologic load. However, in these patients, that doesn't matter as much because of their particular outcomes. So if the horse is out of the barn and the first presentation of the disease is a pathologic fracture, so no known history of cancer, patient shows up in the ER with a pathologic fracture, what do? So now you have something that probably needs to be addressed surgically, but you don't have a diagnosis yet. So again, you want plain x-rays of the fracture. You need to complete staging, and you need a biopsy of either the fracture site, one of the more easily accessible metastatic lesions, or the primary tumor itself if it's picked up on the staging studies. All of this needs to be done before you fix the fracture. If there's polymetastatic disease everywhere and maybe an obvious primary like a huge renal mass, then you can proceed with surgery and just biopsy the area during your fixation. However, if it's oligo or monometastatic disease or there's no obvious primary, then you do need the biopsy before proceeding with fixation. This is where you may have to call your interventional radiologist or your pathologist in after hours or on the weekends to get this taken care of so you can get the patient treated in a timely fashion. If biopsy or frozen section during surgery shows metastatic disease or it's disseminated multiple myeloma or lymphoma, then you can proceed with a locked intramedullary nail for the long bones. often unreamed intramedullary nails due to propensity to spread tumor along the canal or into the venous system. However, what a lot of people use is RIA, irrigator aspirator, so that it can help suck that tumor out while providing reamed fixation. Reamings can be used for biopsy, but they're often of poor diagnostic use because what you end up with is a few scattered cells rather than the architecture of the tumor itself. So in many carcinomas, that's okay, but especially if it's a primary sarcoma, it will be very difficult to get the diagnosis with reamings. If biopsy or frozen section is undiagnosable, so your pathologist says, I can't give you a definitive diagnosis and I'm not sure that this is cancer or not, then you need to postpone definitive treatment until the diagnosis is confirmed with permanent section. And so that may mean putting the patient into a splint, an X-fix, traction, whatever you need for comfort while you're waiting for final diagnosis to come back. If the biopsy or frozen section of the fracture site shows a primary sarcoma, you want to postpone definitive treatment as above to begin neoadjuvant treatment if it's an osteosarcoma or Ewing sarcoma, or to get to an orthopedic oncologist if it's a chondrosarcoma. If biopsy shows a primary sarcoma or undiagnosable, but staging showed multiple bony and visceral mets, then you can proceed with a locked intramedullary nail for long bones and send multiple intraoperative biopsies for permanent section, just so that you can definitely nail down the diagnosis. However, when the tumor is already that metastatic, we know the prognosis is relatively poor, and we know chemotherapy is going to be the mainstay of treatment here as opposed to surgical resection. So let's say you have an impending or actual pathologic fracture that's not in the middle of the diaphysis of a long bone. As we talked about before, the proximal femur is a common site for metastasis with impending or actual pathologic fracture. So in this particular place, you want to consider a cemented hemi-hip arthroplasty or total hip arthroplasty with or without augments or cages as needed if the acetabulum is involved, with adjuvant radiation therapy, especially if they're capable of undergoing surgery and survival is greater than 2 months to see the benefit of that surgery again. Loosening is usually due to tumor recurrence and continuance despite radiation therapy. So when you're in there, you do want to scoop out or resect as much of the tumor as possible. No matter what, you do want to follow with radiation therapy to the area, and that's why we do cemented, including cemented cups, because the radiation will significantly inhibit bony ingrowth and ongrowth to those implants. You can consider a long stem hemiarthroplasty if proximal femoral involvement is noted and it's a tumor with polymetastatic disease or known metastatic disease distal down the femoral shaft. If there's no obvious distal disease, then you can get away with just a standard length hemiarthroplasty. A calcar replacing endoprosthesis versus polymethylmethacrylate enhanced DHHS for intertroch involvement, a recon nail for subtroch or shaft involvement, and then a plate and screws with or without PMMA versus endoprosthesis for distal femur involvement. If the lesion is epiphyseal or metaphyseal, resection and endoprosthesis may be preferred for larger lesions, and simple curettage with PMMA plus plate and screw osteosynthesis for smaller lesions that are contained, versus osteosynthesis alone due to the risk of implant failure depending on the prognosis of the patient. Mega endoprosthetic reconstruction, including intercalary for midshaft lesions, provides for optimal treatment of femoral metastatic disease in patients with a long prognosis with satisfactory functional outcomes based on lower complications with this than throwing a nail down it. They live 3 more years, but the nail fractures in half at some point, and you've got a non-union from radiation and presence of tumor and bigger problems that now they need a bailout to a total femur replacement. You need images of the entire length of bone first to rule out skip lesions up and down the bone when you are considering any of these particular treatments, because again, you may need longer stems, you may need a plate instead, you may need a total femur replacement. It may completely influence your operative approach. You can consider resection with reconstruction or osteosynthesis of radioresistant mets due to the risk of implant failure by tumor progression, such as renal cell, lung, melanoma, pheochromocytoma, transitional cell carcinoma, and others, rather than post-operative radiation therapy if life expectancy is long enough to where they're going to see their construct fail. Resect the met rather than radiation to avoid the radiation-induced morbidity and implant infection risk if symptomatic and the bone is sacrificial. So for instance, rib, clavicle, fibula, or iliac wing, you may just cut that out alone with no additional reconstruction. If there's extensive bony destruction, you want to shell out as much tumor as possible at the time of fixation and replace that, as we talked about before, with PMMA rather than bone graft. You can consider preoperative embolization within 6 to 12 hours of surgery for highly vascularized lesions just to cut down on blood loss. So renal cell, thyroid cancer, and melanoma are the classics for this. It can also be used as an adjuvant for difficult to resect tumors like sacral aneurysmal bone cysts or giant cell tumors, or recurrent giant cell tumors, or multiple myeloma in flat bones where you can't get a tourniquet. Radiofrequency ablation can be considered for bony lytic lesions at the bone soft tissue interface with or without prophylactic fixation or PMMA, with or without cryotherapy, with or without rebar to the defect, depending on the size and the location again, as well as the adjacent structures in terms of the kill zone of the radiofrequency ablation. But sometimes this can be accomplished in a much more minimally invasive fashion than an open surgical procedure. Finally, you can consider amputation even in the palliative setting. This is reserved for multiply failed prosthetics, refractory pain or infection not controlled with suppressive antibiotics, a fungating tumor through the skin, or severe symptomatic neurovascular invasion, or if the patient's already a non-ambulator. There's worse functional outcomes and cosmesis with knee disarticulation amputation compared to an above knee or below knee amputation, despite better pain control, actually. So this has nothing to do with metastatic disease, but I threw this in here because it's a commonly tested topic on the OITE and boards, and that's amputation level and energy expenditure. I won't belabor the point and read this to you, so I'll let you pause this at your leisure and study this. But basically, the higher up you go, the more energy you have to spend to continue to ambulate. It becomes more and more difficult the longer the prosthetic is. Here's a list of my resources. And then we'll close with my typical Pacific Pride slide. This is the Blue Basin as part of the John Day fossil beds in the central desert of Oregon, about 4 hours east of Corvallis and about 2 to 2.5 hours north of Redmond, Oregon. And this picture actually doesn't do it justice. It's basically highly turquoise-colored badlands, and it's an amazing sight, unlike anything I've ever seen on this planet. So once again, if you get the time and you have the energy, it's a really cool spot to see that you'll never be able to duplicate. Thanks for your time.